Good afternoon, doctors and coders. Welcome, welcome. Oh, what a delight it is to see real faces and feel real energy and hear real heartbeats. Thank you for making all the effort to be here. I'm so glad to see you. And welcome everybody that's streaming live. You don't know what you're missing, and I'm glad you're here too. My name is Jan Blanchard. I work with PCC on the team called Getting Paid. So as you can imagine, coding is an integral part of that for pediatricians in the US in 2024. And back by popular demand is this course that Dr. Krekamey Craig and I will provide to you and for you and with you today. This is a mashup of the things that we know are the most important parts of getting E&M right. So we married coding expertise with clinical expertise, and this is what was born. So in only its third. We did this once. We've done this is the third time now we've done this talk together. So Dr. Craig gets all the credit for seeing the gaps in this and putting this together. This was their brainchild, and we will perform it all for you again. Some gratitude that I want to show is first for Dr. Cressley. I was so deeply into your talk earlier today. Curiosity is my superpower. So hearing that espoused and having somebody explore the benefits of that, you said it so beautifully, and I took away a handful of things that even in my deep curiosity I had never pondered. So more food for that mill, thank you. Grist for the mill. I'll mix metaphors for the next 90 minutes, so bear with me. So without further ado, we will get into the content of a doctor and a coder walk into, not a bar as we did last year. We moved on to a phone booth in order to realize our superpowers and get our costumes ready. As usual, this stuff is an exploration. We're not trying to tell you which codes to use for each and every encounter that you're trying to get paid for, but this is all exploration, and use your common sense. This all should be applied to the context in which you are rendering care and coding. So take that common sense for what it is worth to you. And these are the things that we're going to try to achieve in the next 90 minutes. We will explore with you the leveling requirements for making E&M choices, E&M level choices. We're going to apply those leveling concepts to a handful of actual vignettes. So clinical vignettes, that's where that marriage happens. We'll take the theory and put it into practice. And the idea of doing all of this is to improve your confidence in your coding and your leveling. The number of times you have to make this choice every day in your practices is staggering. And if we can shave just a couple seconds off of each of those deliberations, we will give you back some of the precious time that you spend caring for kids. So those are the goals that we have. What I'm going to do before we head into the vignettes and even the E&M specifics is just take a couple of minutes to briefly go over the highlights of some CPT changes in 2024. So starting first with there are some changes, as you imagine and as you expected, to the COVID vaccine. Appendix Q in your CPT manual is dedicated to all of the COVID vaccine codes. So if you didn't know that, there is a one-stop shop for those. The handouts are in the app. So if you want to access the blue links in any one of these slides, you can do that right from the app, and those will open up for you. So I'm a big fan of letting you look at the slides when you want to see the details that we're talking about. If I'm reading to you, we're not going to get through 90 minutes of it, and your questions are going to be so much more meaningful to me than me reading things that I wrote down. So slow me down, do one of these, slow down and say something again, and we'll also be taking questions, I believe, to the end, because it makes it easier for our remote folks to get a word in edgewise. If there's something that absolutely can't wait, please do step up to one of the microphones that you'll see in the center of the room. That is much, much easier for the folks at home to hear you with, and I won't be putting words in your mouth when I try to repeat your question. So yeah, here are those, the Appendix Q COVID vaccine updates, easy for you to understand. They are manufacturer and age specific, so be sure to document all of those things. Another CPT update, how many folks knew that there is an add-on code for pelvic exam this year? Not a lot of people. You can get paid. There is a 99459. I keep saying 95 because I'm used to talking about well visits, but 99459 can be billed to payers. Whether or not they'll pay it is a billing question, but I encourage you to send it, report it. A write-off is a write-off, but if you're not reporting it to them, and if their policies change and they do begin making payment or they increase their payment, having reported it is going to have that data in your hands. You can retroactively ask for reconsideration or hold your payers to the policies that they amend or make retroactive. They can be listed in addition. This is not in place of anything. This is when you do a pelvic exam, either in a sick visit, a well visit, or a consult. These are the code ranges that you can add that to. So give it a shot, see. I always encourage reaching out to your payers, your biggest payers, in advance to streamline it a little. If they have special reporting requirements for this new code, they'll give you the best information, theoretically, ideally. They'll give you good information about how to report that to be within your policy range, your policy limitations and expectations, and might get you paid just a tiny little bit faster. Right. Oh. Okay, first question that I'm repeating is does that require a 2.5 modifier? And that is a billing question. So the coding answer is no. The 25 distinguishes services from one another when there's confusion about whether they're distinct. That a payer would admit in public that they could confuse an E&M code with a pelvic exam makes me question a lot, even more about their behavior and their means. But yeah, the coding answer is absolutely not. But the billing answer is they may require it, of course. This is taking all of my self-control not to call on people with questions, and I am going to ask folks to hold them if you can, or go to the microphone. If you really can't wait, it's, like the bathroom, go to the microphone. I don't know why I said that. The next code is G2211. How many folks here are billing for it and getting paid for G2211s? Billing? Okay, I'll ask those two questions. Billing, who's billing it? Good answer. Who's getting paid for it? Most subset of those. Okay, so 50-50 of your payers are paying the G2211. There's so much discussion and talk about this code. There's confusion about what it represents. There's confusion about whether and when to use it. I recommend using it with, in pediatrics, my opinion is there would be a small subset of services where it didn't apply. The idea behind this is that this represents the cognitive load of the responsibility that you have as a pediatrician to be the focal point for all care for a patient. So that you manage, that you coordinate care for, they specifically mention chronic disease in the descriptor. You can see here, visit complexity associated with medical care. They go on to say services that are part of ongoing care related to a patient's single serious condition or a complex condition. In addition, they do mention, and AAP's interpretation of this includes that cognitive effort, that cognitive load of making sure that the way that you're caring for that patient isn't going to interfere with other parts of care, other care that you're managing for them. So the logic there and the AAP's position on this is this will be reported with most every service where the longitudinal relationship that you have with that patient is meaningful in the way that you care for them. So that you understand your patients so well speaks to the applicability of this code. That you care to keep them safe and that you're doing mental gymnastics to be sure that the care that you recommend that day and the plan of care that you offer is in keeping with everything else that patient has going on in their life. You're looking at the pharmacy where they can afford to fill prescriptions. You're looking at the specialists that are in their neighborhood so that transportation barriers aren't preventing their compliance with your plan. You've got all of this in mind most all of the time. So there is a small subset of services where you could reasonably say, yeah, G2211, I didn't have to think about anything outside what I treated today to make sure that I gave this kid the best care possible today. All right, it is absolutely a judgment call, and the AAP has posted and provided a whole lot of guidance on their interpretation of it. And at the end of the day, if you start fighting with a payer about whether you're going to hang on to the money that they gave you for a G2211, not that they gave you, that you earned for a G2211, then the AAP is going to be who backs you up. And being in alignment with their interpretation of this and with their policies on this is a really good idea in my opinion. So I have in here, the April 2024 AAP coding newsletter has good detail about this. And so if you are, there's probably a small subset of folks here that are not PCC clients. If you are a PCC client, you have access to the coding newsletters right from the EHR. So you can seek out that April 2024 newsletter. Anybody that doesn't know how to access that, find me and I will happily show you. It's one of my favorite things. And wrapping up, oh, not quite wrapping up, but some things that like didn't really fall into necessarily into a whole coding category unto itself. There are two things that are reinforced in the coding guidelines in the AMA manual this year, and they are these two things. They actually explicitly stated the golden rule of coding. They spent ink and paper and electrons to write out that choosing the CPT that accurately identifies the services performed is the way to choose a code. Your laughter is so validating to me. I don't know how many times I ran my highlighter over that and then wished I could erase it. I'm like, that can't be what they mean. It is what they mean. So after however many years of the AMA producing CPT manuals, they decided to say it out loud. So there's that. There is no further change. If you see that this is it's in bold and green in your manual, that's all that it amounted to in my interpretation. They also go on to distinguish between codes that have time ranges in them, timed services, and others that don't. So you'll see in one of the updates that I mentioned about E&M for 2024 is that it's no longer, when you level based on time, it's no longer between 10 and 19 minutes. It's the time spent that day must meet or exceed a minimum minute number for each of the visit levels. That is distinct from other types of services like the ones I mentioned here, like IV hydration. There are still minute ranges for services like that. If you're rendering services in your practice that have those minute ranges, the midpoint still applies to those. How many folks here don't know what the midpoint rule is? Bravery, thank you for that. The midpoint rule says that for codes where you have a range of minutes, where if your minutes fall between, the midpoint rule says that you don't have to exceed the highest number in that range in order, or even meet the highest number in that range to bill for that service. I'm sorry, to bill for the next highest service. So an example is always better for illustrating this than my own words. If you had a service like IV hydration, and I'm gonna get the numbers wrong, I don't have the ranges memorized, but if there was between 30 and 45 minutes of IV hydration, and you documented that there were two levels of service. One was 30 to 45, the other was 46 to 60, say. And you documented, so 30 to 45, 40 minutes. If you documented 40 minutes, on its face, it would look like that lower level of IV hydration code is what you would report, because it's 40 is between 30 and 45. But because 40 exceeds the halfway point between 30, I know, this is all crazy. The looks that I'm getting are like, what are you, this can't be serious. Because 40 minutes is greater than the midpoint between 30 and 45, you can actually bill the higher level of hydration service. That's what the midpoint rule explicitly states. So the reminder is that although for anything that has those definitive start and stop ranges for any timed services, don't sell yourself short. You make use of that midpoint rule. It still exists. It doesn't exist for E&M, but it persists for other code types. There is a reminder also in this year's manual to be clear about the units considerations for these timed services. Some services are in minutes, others are in hours, and still others are in days. So pay close attention to the units that you're working with and be sure that it matches your documentation and the experience that you had in treating your patient. And as usual, they're telling you what you can't do as much as they're telling you what you can. Do not include any time spent in these timed services when you're coming up with your E&M total. So when you see that little caveat at the end of all the E&M discussions that says time not spent in other services, this is those other services. Okay, so they're kind of tying that all together and making explicit the way that they expect these codes to be used in concert. There is also an update or an explication. They're more explicit about AV and audio-only services. So if you are rendering telephone care, if you're rendering real-time audio-visual care, telemedicine in those two types of telemedicine, they have set standards for what the encounter must be comprised of to qualify to be billed as audio only or audio visual synchronous. And those are listed here. The statement in general is that the totality and quality of the communication of information in a visit like that must be of an amount in nature that would be sufficient to meet requirements for the same service if it were face-to-face. So just because you were on the phone, if it really wasn't quite a full encounter, there wasn't the back and forth, if it doesn't comprise what you would consider a significant encounter, don't bill it that way. They're saying that your documentation will have to prove that it is a significant encounter, that it wouldn't be judged differently if it were face-to-face. All right. They also go on, and I wanted to explain that the way that I worded this, the services listed in appendices P and T, for some of you this may be the discovery that appendices P and T exist. So there are lists of codes in the back of your manual that explicitly describe the codes that may be billed as synchronous AV and audio only. So if you're doing a lot of that, make sure that the codes that you're billing for that kind of service that you're reporting them fall into those two appendices. Either of them, it shouldn't be in both, hopefully. And this is just the explication of those criteria. The evidence has to support that rendering services by audio only or synchronous AV has these benefits. So there has to be some reasonable expectation that it facilitates diagnosis, that you're doing it for a good reason. You're not just doing it because you prefer AV or you don't feel like getting out of bed in the morning and you can do it from home. They're saying that there must be justification for why you chose that mode of encounter. The good news that I see in this list is that the enhancement of access to care, that third bullet point, sounds like the most frequent, what I would expect is the most frequent reason that you're rendering care like that. It is making it easier for patients to reach you if they're way outside the city that you practice in. It keeps vulnerable patients who would otherwise be exposed to things in the office that you don't need them exposed to treat that, whatever condition they have that day, to treat that safely, you're keeping them safer. So I don't feel like this is a huge change from the judgment that you're probably using for when telemedicine is appropriate, but again, it is codified, and I wanted to be sure that you understood why that ink was green this year. All right. They have also made explicit a thing that I've gone into detail about in almost every E&M talk that I've given since the changes in 2021, and that is the definition of risk. The concept of risk exists in several places where you're making judgments patient by patient, but the place where risk is considered an element of your E&M leveling is reserved for and specifically limited to the risk that is represented by the plan of care that you choose for the patient. Not only choose, but also discuss with the patient, and I'll come back to that. So the risk of any complications or morbidity or mortality of patient management, so your plan of care and any additional diagnostics. It's not the risk of the disease that they're being seen, the disease or problem they're being seen for. That's relative, that definitely relates to the leveling, but specifically when you're choosing that risk level, it's not the risk of the meningitis, it's the risk of the spinal tap, if that helps to make that difference explicit. All right. So they codified that again. It's been this way since 2021. There's not been a change to that definition, but being clearer with folks about which type of risk they're talking about when you talk about the 2 out of 3 elements when you're leveling by medical decision making. This is what they mean. Did I make those points? Split or shared visits were a popular and numerous discussion topic in 2024 changes, and they relate to the distinction between whether a physician is rendering the care or directing the care, and these elements here are the ways that AMA will accept that distinction. So what I see in the split and shared visits, where I see the tension in this, is that the folks that are working at the MD level are getting the best payment from your payers. And folks that are not working at the MD level can get as little as 85% of that, of what the MDs are getting. So you want to avoid that. For every opportunity that you can, you want to be sure you're billing the MD as the service provider. You don't want to miss opportunities to capitalize on that additional 15%. This is where that definition is made explicit in AMA. If the physician or other qualified healthcare provider's time is the majority of time spent on that patient that day, their own personal time, even if another person was involved in that care, another clinician that is not at the MD level was involved in that care, so long as the majority of time was spent by the MD, so long as the MD spent more time than the mid-level or someone at another licensure level, you can bill that under the MD. It doesn't have to solely be the MD. If the physician or other qualified healthcare provider made or approved the management plan and takes responsibility for that plan, so doesn't delegate in entirety, but stays involved in the care of that patient and takes responsibility for all of the management decisions made, that is another factor in favor of billing under the MD. In addition, the MD does not have to personally assess the independent historian or personally order reviews or tests. That can be done by someone at another licensure level. It doesn't have to be done personally by the MD. And the MD does not have to personally interpret tests or discuss management or test interpretation with the patient and their family. So those things don't have to be personally done by the MD. It does have to be majority time of the MD, but those other things do not have to personally be done by them. I don't know why Dr. Fishkin's pointing. Oh, you're absolutely right. I'll restate this for clarity. I've been saying does not when I intended to say does. Small difference. Yes, you may report the MD not report them. You may report MD services when these bullet points are matched. So yes, bill for the MD when their time is greater than anyone else's in care of the patient that day. And yes, when the clinician made or approved the management plan. No, so I'm sorry. So does not have to personally assess the historian, but does have to personally interpret the test and discuss management. So that distinction. I thought I got all of them wrong. I only got the middle one wrong. So I only got the last one wrong. The MD does have to personally interpret tests and discuss management. I apologize. I know I just introduced a whole lot of confusion to a thing that's already confusing. Thank you for the heads up. Yes. I can't help myself. Yes. Okay. The question is, what if you are consulting with another clinician in your practice, and they may even come in and assess the patient with you? How do you account for that in reporting services? And what I hear in that question is, do I mash their time together and report everybody's time? And the answer is absolutely not. If it's concurrent, if it's simultaneous, you're both in there at the same time. You would report concurrent time, not serial time. If that, I think I said that backwards. You would not report for both clinicians. They're both of their time. The other point that I find in that is if that other clinician has a different subspecialty to you, so if you're primary care and they have a dermatology subspecialty and you've asked them in for that, that would factor into the data and tests and data. That would be consulting with someone of another subspecialty and would give you complexity points there, but not if they are in the same they report the same taxonomy code, that kind of thing. Thanks. Now that I've thoroughly confused everyone, I will fully expect the clarifying questions at the end. And this is related to incident to billing, which is another question that we get all the time. And incident to billing, the resource that I have that is most widely applicable is the CMS definition of what incident to billing is. And that's why I've included it here. That link will take you to CMS's page that lays out what their definition of it is. And I rely on that. I fall back on it because I can't say with any certainty what the number and variety of payers represented by all the practices in this room would say about incident to billing and how they might interpret it. The strict interpretation by CMS is that you cannot bill MD services for anyone that's not at MD level rendering care if there is any new problem or it's for a new patient. So they've strictly interpret to say CMS will not pay if that mid-level is just shortcut. I don't intend any disrespect, but when it's mid-level services, they cannot be acting autonomously. They are doing nothing more than checking on the progress of your own care plan. So it has to be a problem that the MD saw already and set up a plan of care for, and the mid-level is simply making sure that things are going along as they expected in that plan of care. No new patients, no new problems. And in primary care peds, the workflow to manage that and schedule dependent on what the problem is, it sounds to me like it's more work than it's worth to make up the difference. That's your judgment to make. I mean, that 15% is not insignificant. And if you have the facility and flexibility in your practice to adapt to problems and encounters, if you've got a parent that brings up a surprise problem, that goes from being able to bill for the MD, unless the MD comes in and gets involved, that problem goes from, or that encounter goes from being billable at the MD level to then having to be billed at the mid-level. Is that one clear? I get that question so often. It is a really easily misunderstood. Naira. Yeah. Can I beg you that it's right there? The microphone's right behind you. Thank you. Oh. Sorry, Kristen.
Okay.
Thank
hey,
you.
Jen.
Hey.
Question. So did you say new patient and new problem?
Yes.
So if it's an established patient with
Only established patients, only established problems. So it has to be, even the problem has to be something that the MD has already seen and set a plan of care in place for.
So established patient with a new problem.
No new problems, no new patients in any case. That's why I've been saying it that way. I thought that clarified it, and that 15% is really attractive and necessary. That, you guys are on a thin margin to begin with. I totally get the motivation, but hanging on to that money is going to be much more easily done when you're adhering to these and documenting accordingly.
Okay, so just to clarify, the mid-levels can see new patients but not bill at the MD, or they cannot see new patients, no new problems?
No, the new patients I wouldn't imagine would have an established problem. If they're a new patient, the MD couldn't possibly have seen them.
No, the mid-level. Can the mid-level see a new patient?
Oh, for sure.
Right.
Yeah, they're
okay,
working at the top of their license. For
right.
sure.
Okay.
Yeah, thank you for that. All right.
Jan, just one more.
I've loosed the monsters.
You really want to clarify real quick. Okay. So we are at practice that have MDs and nurse practitioners. We understand and we do incidental billing, which is why we do not schedule our NPs, new patients, but we do have our NPs work as like a pop-off valve for our established patients that are sick during like the flu season. And so if we schedule a patient for a sick visit and it's for an ear infection that the primary care doctor or the physician has not yet seen this patient on, are you saying that we cannot do incidental billing for that situation? Or
I'm sorry, repeat that.
So our established patient is being seen by our nurse practitioner, and they have a new problem of otitis media that the pediatrician has not yet to see this patient for.
Has yet to see the patient for?
Right. The patient comes in, they see the nurse practitioner, and it's otitis media. They haven't treated the patient for it before. Are you saying that NP cannot? We are unable to do incidental billing for that reason?
That would not fall into CMS's guideline, CMS's definition of incident to. I strongly encourage you to check with your payers. I mean, I want to say, Dr. Kressler.
Yeah, let me steal this for
Florida.
3 minutes. First of all, the time has come to get rid of incident to building. Almost all payers now want your NPs and PAs to be credentialed with their own, and yes, they get paid at 85% of rates. That's the way it is. But make sure your contracts don't have them 85% of vaccine admin code. Get that carved out, so it's just E&M work. It's not anything else that goes with it. I just consulted with a practice in Florida who got $650,000 take back because they've been doing exactly what you guys are doing. The way this works best in pediatrics is if you're in a specialty clinic. If a patient comes in with Crohn's disease and then sees the NP who's managing the pediatric gastroenterologist's list of what to do with Crohn's disease, they can bill incident to. This doesn't work in a primary care practice unless you have someone who treats chronic disease and you have a nurse practitioner who follows along with them and is basically following their protocols for how to treat kids with X, anxiety, depression, obesity, asthma, whatever. But it really doesn't work for any acute problem in pediatrics. It is not worth the risk when they come at you unless you have it in writing. So ask all of your payers, what is their incident to billing rule for NPs and PAs? Ask for it in writing, and then if you have it in writing, make sure they don't change it in a follow-up bulletin that's in fine print somewhere next year when they renew it. It is not worth getting that money taken back from you. It crippled a practice and almost put them under.
Thank you. All right. Oh,
Quick question, following along what Sue just said, and I don't remember the codes, I'm sure you will, Jan. The CPT codes that are fairly new, where you're working in conjunction with a specialist, where you can bill for that time, referring to the specialist, getting their information, their advice, and then you, your NP, taking that with the patient in the office. First of all, I don't remember the codes. Do you remember them?
yeah, I'm not sure which ones you're talking about. Yeah, I mean, we can talk about it while Dr. Craig is speaking, and I can follow up in our Q&A.
Okay.
That sound good?
Because I'm wondering if those codes would be applicable for this discussion.
Oh, for this. Yeah, if they're, to Dr. Cressley's point, if they're not E&M, technically E&M, it shouldn't matter. The contracting effect of this is 85% of the E&Ms.
They are
and all others.
E&M.
Yeah.
They
Then
are.
let's talk about which codes those are, and I'll try to have more detail for everybody in the Q&A. Thank you. All right, in the interest of time, look at time. There is a long list in CPT 2024, page 14 to be exact, of the activities that you can include in the minutes that you count up on an encounter date to determine whether you want to use medical decision-making or time to level that encounter that day. The point that I want to bring to your attention is that very last bullet point, care coordination, that's not separately reported, so activities that are not part of the monthly codes, and if you don't know what those are, I can talk with you offline about it. If it's not separately reportable time, that all of your visit preparation, your history, your exam, and or evaluation that's germane to what we're going to talk most about today. Time is not what we'll explore today. Rather, we're going to look at a bunch of vignettes. Dr. Craig has prepared a whole lot of vignettes that bring this into your reality. Take these concepts and apply them to the ways and the problems that you see and the encounter types that you encounter. So that is the end of the updates for 2024. Just for completeness, I wanted to include those minimum times as of 2024. Like I said, it's no longer ranges that you'll use to determine the level based on time. Now your minutes for an encounter must meet or exceed each of these values in order to bill those services, to report each of these codes. So meet or exceed these minimums. And these are the three elements that I keep referring to in medical decision-making, leveling by medical decision-making. Those are number and complexity of problems addressed, the amount and or complexity of data that you consider in treating the patient that day, and again, repeating the risk of morbidity from additional diagnostic testing or treatment. So those are just the overarching elements that you'll use in this exploration that we'll go through next. Also in the handouts is this 2024 adapted E&M coding tool from PCC. You can download this and print it out, and I smile and jump a little bit every time I hear someone say, I've got them plastered in my encounter, in my exam room. Even better than that, even happier, is that the laptop desktop. That's the newest idea I've seen for that. Thank you. The other place that I've seen it is in protocols. In fact, the practice that Dr. Craig is with, BCD, they've got that all worked right into their protocol so that you can put right into the encounter why you think that's a 214, why you assess this as a 215. So put it right where you're going to use the information, all the better. All right, that is my spiel. I'm going to invite Dr. Craig up to take us through the remainder of this and hope against hope that I left you enough time to do it all.
Jan, the codes are the 99446 to 49, the interprofessional consultations.
Oh, awesome. Okay, let's take a look.
Okay.
Hey, good afternoon, everyone. Happy to be here. Yes, thank you, my BCD cheering section. I had a little bit of a headache today, and I was like, boy, I wonder if it's the altitude. And then I was thinking, you know, I think I'm dealing with CHIPS things, adjusting to these new progressives, and I'm not really sure what screen I'm going to look at, but then I realized, no, probably because I was out with the karaoke group last night. Perry, fantastic job, and Biblica, I mean, I got a whole new perspective on salt and pepper. You killed it. All this to say, one of the best things about the PCC conference is really getting out there, meeting your peers, learning who they are, finding what's different and new in their worlds. You will grow the most. Trying to do this conference remotely, you lose 90% of what it has to offer. So anyway, on that note, I'll get started. I am not the most tech savvy, so this is kind of funny. I somehow erased my first slide, but I've got it. Anyway, so why is it that I decided to do a coding talk? I'm not a coder, I'm a pediatrician. I just struggle like the rest of you guys trying to figure out what's the right level of coding. And I wanted to go to a talk that was sort of like this, but it really just didn't exist. And so I turned to Jan and I said, Jan, please, I think we need to combine forces because I don't have the coding skills, and she really needed somebody to provide the vignettes so that we could get a full picture. So hopefully I've done that today. I want to give a special thanks not only to Jan, who reviewed all of my slides, but also to Stephanie Montine-Turner. She is basically the AAP coding hotline. So not only do I have the coding expertise of Jan, but I wanted to make sure with the AAP that what I'm saying is sort of in line with their thinking. Because there are some nuances that I'm going to present today that, as I've stood up here before in 2 prior lectures, that people start to, I want to say argue with me, but they're like, but, and I agree with them, but this is really the stance of the AAP as well. So, and I'm going to just apologize from the start. Some of these vignettes are a little long, but they are real cases, and I really wanted to mimic our scenarios that we see in the office, because when we give very simple examples, the coding seems very simple, and then all of the nuances that we encounter are lost, so we can't figure it all out. And this is really sort of like, I don't want to call it advanced, because I wouldn't even call myself advanced, but just sort of like the 200-level course on coding, so you can get a sense of what's going on. Unlike Jan, I welcome all interruptions. I think the way to make this the best learning session is if you interrupt and say, oh, well, what about this? Hopefully I can answer it, and if I can't, I got Jan right back there to answer it for me. Let's see, anything else before I get started? I think that's basically it. Okay. Okay. Oh, right, so I just wanted to say that BCD does self-coding. Why do we do this? Yes, we want to have accuracy within our group and make sure that we have the best coding possible in all of our care centers. And it's tough when you're, 10 care centers, 12, 13 locations, it's tough to have consistency. We do it for that. But also, problems arise, and we discuss the issues, and we decide amongst all of the managing partners, and then we'll contact the AAP coding hotline and come to a final decision. And a lot of the vignettes that I'm presenting here are things that I've run by through the year with the AAP as well as with my fellow docs. Okay, so vignette number 1. A 6-month-old X34-week premature male presents to our office for his first visit. The parents have brought him to the office because they would like to discuss nirsevimab. The patient's past medical history is significant for poor weight gain and chronic severe reflux. His weight has improved and he is now on the chart, and while the reflux continues to be problematic, He is gaining adequate weight with the thickened feeds and no medication. He currently weighs 6.8 kilos in the 7th percentile. The physical exam is essentially normal with minimal tenderness of his abdomen consistent with reflux. Diagnosed a 34-week preemie with chronic reflux. And the plan is, after discussing the pros and cons, the parents decide to give nirsevimab, and a milligram of nirsevimab was administered. So the first point I want to make is only the clinician can determine if something is acute or chronic. It is one of the things that's very difficult for coding experts and insurance companies, so it really falls on our lap to say it and document it. So by chronic, the CPT and coding guidelines say you have to expect the problem to last at least a year or a lifetime. Something that is recurrent is not chronic. So keep that in mind. And otherwise, they're going to assume it's acute if you don't spell it out that way. All right, so how would you code this? So for problem, and this is my first error, this is actually a problem level 3, not 4, sorry about that, for one stable chronic illness of reflux. The data is also a 3, as the parents are the historians. The risk is also a 3. At this visit, we didn't discuss medication, but had we discussed reflux medication, you could have made this a level 4 risk, even if you didn't administer this. So I would code this in 99203 with a 25 modifier, as it's a new patient, and you're billing for the RSV as well as the admin code. Any questions at all? Okay, so a couple of things, just when I just say, I'm going in and out. The nirsevimab. First of all, even though it's not technically a vaccine, this is the way CPT interprets it. So when you're dosing nirsevimab, that is not medication management, all right? So think of this as a true vaccine when you're dealing with coding. The other thing is if this patient had come in and that's all they wanted was the Beyfortus injection, then you are only billing for the Beyfortus injection and the admin code, but no visit. Okay. Oops, uh-oh. I'm gonna need help. I pressed something. Oh, here we go. Here we go. Sorry about that. All right. You might want to stay close. I have terrible luck with computers. Anyway, okay, so remember to bill the counseling code, and this is one of the points that the AAP asked me to really make clear to everyone, that the counseling code for the administration with the vaccine requires that you say who gave the counseling and when it was given and what questions the patient may have discussed. So in our charts, we have these pre-written boxes that we just check off, but it's important in your charts, if you don't, that you have something written for it. Okay. Yeah. Oh, you're going the wrong way.
Okay, so it wouldn't affect the coding in this case, but say you had done an RSV test and you have the mom as historian, and so the question was, if dad is there as well, does that get you to a level 4? And my inclination is to say no, 2 separate historians do not get you to a level 4. So I just wanted to confirm that and make sure everybody knew.
100%. That is just one category. Do you have an independent historian or historians? It doesn't matter if there's 1 or 2. Yeah. Just go to the mic if you don't mind. No. Jan. So she just wanted to say that the more people in there, the more people you could count towards medical decision making. But I'm just going to say no on that one. The only other comment that the AAP actually made about this was, don't be afraid to give the nirsevimab. The The CDC is really working hard to help practitioners, and they're fighting with insurance companies such that if we do not know the status of the maternal vaccination for RSV and you give the Beyfortus, it is an indication to give it, and they cannot deny it for that. That also includes if you don't know, if the mom got the RSV vaccine, but you're not sure if it had been 2 weeks or not. So I will say that we went into giving the Beyfortus vaccine because we really thought it was a very important thing to do, and we were hoping to not lose money, and in the end, it has become profitable, not outrageously so, but enough so to make it worth your while. So I encourage you to talk to your insurance carriers and go for it. This is an important vaccine, and you will be reimbursed very well. You just have to be careful that you're doing it correctly. Okay. Go ahead.
The only question I had was, you had a stable chronic illness there. Are you using the prematurity or the reflux? Because you said it has to be at least a year. And so...
I used the reflux because it was still being treated with thickened feeds, not medication, but with knowing the premature status, I did expect it to go on for a year.
Okay, so you were making the assumption it would last at least a year.
That
based
was,
on the
yes,
prematurity.
correct. And that was why I used that example, because it really, no insurance company can say, well, I didn't think it was going to last a year. Well, when you have a preemie who's still getting treatment for the reflux and you think that it's going to go on for a year, that's your call. That's not their call.
Okay, that makes sense. Thank you.
All right, vignette number 2. An 18-year-old male presents to the office alone for evaluation of 5 days of cough and congestion. No reported fever, good appetite, energy is adequate, but he is waking frequently at night due to the cough. Physical exam is overall normal, nasal passages are swollen, and there are some coarse breath sounds on lung exam. You diagnose a viral bronchitis, and the plan is for the patient to follow up next week if the symptoms persist, and was told to take Benadryl at night to help with the postnasal drip and hopefully improve sleep. So how would you code this? You would code this as an acute uncomplicated illness, a viral bronchitis, only a level 2 for data, and a level 3 for over-the-counter medication management. We recommended Benadryl. You can just decide whether or not that was a good call, but that is the case. And so here you would bill a 99213 and a G2211. So I wanted to say something just from BCD's standpoint, and yes, we are a very large group in New Jersey, and every state could be different. But I will tell you that when we first started billing for the G2211, we had variability of follow-through in the different care centers, and then we started to see the money rolling in, and then we said, oh no, everybody is going to do this, and this was being changed in the billing office, and we made sure that everyone was following through. So just to give you a sense of our numbers, from mid-March through June, we collected $115,000 for the G2211. It was billed almost 19,000 times, and 56% of the plans were paying, and this code was reimbursed anywhere from $7.76 to $40. So it's worth it. Do it every single time. The only times you can't do it is if it's a modified visit with a 25 modifier on the visit. That's it. Otherwise, I don't care if they're a new patient, bill it. They're going to be your patient. The only time I guess that you couldn't use it is if they're visiting from out of town and you're not going to be their primary caretaker, then no, you can't bill it in that case. Yes, question.
So if it's not getting paid, is that cost going to your patients? Because that's what I worry about is then...
Don't worry about it. I'm sorry.
I mean, legally, do I need to be worried about it?
No, I'm telling you, it's like with any change. This is a small peanut that they are giving us to compensate us for all of the longitudinal work that we do. We deserve it. You can apologize to the patient that you're sorry that the insurance company is not paying for this, but that all of the phone calls and all of the back and forth that we do on the portal messages, that is what this code is paying for. It's a valid code. It has RVU value to it. And by the way, this code, the sad truth is, it's probably going away. Why? Because the surgeons are out there lobbying and saying, well, you're taking some of our Medicare pie. Like, we want some of that money back. And if they fight harder than the AAP fights, then they'll just keep getting more money than we do. And it's really important that you fight for this, and if everybody bills for it, the AAP will hear us loud and clear, and they'll continue to advocate. Yes, go ahead.
So we've been doing the G2211 for a couple months now, and really only like one of our payers is paying, and it's not even Medicaid. Do you have any suggestions on how to negotiate with them? Because our CIN network has been trying.
This is so awesome. I have the president-elect right here to answer your question.
So while you're all sitting here, our immediate past president just started a conversation around the executive team on what's our strategy to get G2211 paid. So we hear you, we're working on it. I, of course, piled on and said, the same old strategy doesn't work. Let's get a new group together to think outside the box. What levers do we have and how do we do them? So keep billing it. And yes, it's dropping to patient responsibility, but in a small number of patients. And then you can decide what you want to do with that. This is really primary care work. Now we found that there's actually specialists using it. And it's probably valid in some specialists who have chronic care of a patient over a long time, but certainly not for acute orthopedic injury that is not going to coordinate it. So we really need to really talk internally about the leverage. Occasionally, AMA and CMS get it right and try to support primary care, and the payers don't play the game the right way, and then we have to figure out what the tactics are. But if we don't have data about how much time you're billing it, and some of that would actually help us advocate, if you don't document it and you don't bill it, we'll never get paid. So keep at it.
Yep.
Virtual question, if I may, from Susan Glasser. She said, our physician network is discouraging G2211 because it goes to the patient. And she wants to know what you think about that.
Well, that was the same as the prior question.
Okay.
That basically, they have to understand that our work is valuable, and that their fight should be with the insurance company and not with us.
Thank you.
You gotta go to the mic. Go ahead.
What do you do for some payers when you bill, say those two codes in particular, and they deny the whole claim because of the G code?
That's a different, yeah. I would say go to that microphone. She's just gonna stay right there.
Sorry. So it depends what happens to your claim. There's a difference between following the rules and not paying for things. If your claim fails, that is a HIPAA simplification administration violation, and I will be happy to walk you through how to fill out the form, which then CMS and then goes back to the payer and says, you're obligated to follow CPT codes. You may not fail a claim when someone used the right codes.
Yep. It's worth the bother. That's the bottom line. And that's why I shared our numbers with us. And that was just getting started when we were having inconsistent use of the codes, is that, yeah, they may not all pay, but guess what? You think you're all billing for it? I know you're not all billing for it in your practice because we saw it at our central billing office. So you have to demand the consistency. Go ahead,
One
Lynn.
more from virtual. I'm just pulling this down because I'm very short. Judy Orton says, since we're not supposed to differentially code or charge based on the payer, G2211 is not on the Vermont Medicaid fee schedule, so wouldn't be covered. How would you reconcile charging commercial insurances and not Medicaid?
We charge our Medicaid plan, so I have no idea what they're talking about. And we get paid for Medicaid. And you charge them the same thing. Who cares what they pay? But go ahead.
Right, just to go back to the previous question where your organization told you you should not bill it, it's easy for me to say because I'm semi-retired. Tough luck, that's poor information. What you need to do is go to your state AAP chapter to help you fight, not your organization, but the state who's not paying for it. So I think those of you who belong to that organization have to make a decision. You need to go to the higher-ups that know that's incorrect. I should be using the CPT code. It's there, it's correct. It's up to you whether you fight your organization or not. But go to your AP chapter for help.
Thanks, Rich. All right, let me move on, because now I'm going to regret all the questions. We have a 4-month-old breastfed female with no past medical history presents with a full body rash. Mom states the baby has never had a rash like this before. The rash is worse on the face and extremities. The baby is miserable, constantly rubbing her head and body, not sleeping well, and just fussy. Worth mentioning that this physician just opened a new office, and the patient followed the doctor to the new location, and this is the baby's first visit at this office. So is this a new patient visit? No, it is not a new patient visit. And I asked actually the AAP the follow-up question, which is, let's say they saw Lisa in the first group. Lisa goes and opens up her own practice, but in the new practice, that patient goes to see Chuck. Is that a new patient? No, that's also not a new patient, because that patient is known to someone in the practice, all right? So that's an important clarification. The physical exam is significant for a full body eczematous patches with areas of excoriation and bleeding. Okay, how would you code this? I'm sorry? So right here, the diagnosis is eczema. Sorry, I misspoke, so I was getting ahead of myself. The plan is I discussed possibility of dairy intolerance and removing dairy from mom's diet, reviewed skin products to use and avoid, reinforced importance of skin hydration, discussed bleach baths, and prescribed triamcinolone ointment. So this is a chronic illness with exacerbation for the problem. It does not matter that this is the first time you're seeing this problem. It is going to be chronic. Eczema is not a one and done, unfortunately. This is a level 3 for data, as the mom is the independent historian, and we're at a level 4 for risk for prescription drug management. And we code this in 99214 with the G2211. Yes, Rick? Yeah, go ahead. I'll wait because I'm terrible at remembering to repeat.
Okay, 2 questions. One is, we've just hired a physician. He came from another local practice where there were 2 physicians, but they really divided their patient panel. It was like girl doctor, boy doctor. They didn't interchange patients. So, of course, his patients from his own panel, as they've come over, we understand are established patients. But her patients, he doesn't know anything about them. They just are, the practice closed, and they're looking for a new doctor. Are they new or established? They shared a tax ID number.
So unfortunately, and I'm going to have Jan weigh in, the understanding that I have is that if it was a patient that was familiar to the practice that they were in, and it's not a new patient.
Okay.
For that reason.
Okay. Second question in terms of chronic illness. I'm so glad you used eczema as the example, because that was what I was going to ask about. Okay, so wheezing, first-time wheezer. We don't know if this toddler's ever going to wheeze again, but they probably will, but it's not meeting the definition of chronic asthma. You're giving, let's say you prescribe albuterol. Chronic, acute.
So it really depends on what, you can wait for the next slide and I will answer that. So remind me, just point at me and I'll get back to you if I don't answer that specific question. Go ahead, Rich.
All right, sorry, so Sue told me to come up here. I'm not the president-elect, but in the past I was a SOPM chair of PAC, I was a chapter president, I'm an AP CPT coding trainer. That's why I'm bugging. The way you had it in your description, in your plan you did not write down the prescription med. So I would suggest that you write down the prescription in your plan.
I did, right there, prescribed triamcinolone ointment.
Oh, good, my glasses aren't on, I apologize.
No, all good. All good. No, I appreciate it, and there could be problems in these slides, and I don't want to mislead anyone, so I really do appreciate that, Rich. Okay, next case. A 15-month-old male presents with cough and reported shortness of breath. Wheezing. He started with congestion about 3 days ago, but his symptoms have worsened over the last 24 hours. The patient is afebrile but fussy. The parents gave albuterol overnight that helped. Today, he continues with some increased work of breathing. The parents state that he has been doing great and has not needed albuterol for the last 9 months until last night. This AM, he ate okay, but less than usual, and he continues to drink well. The past medical history is significant for an ICU admission for RSV bronchiolitis at 5 months old, and he spent 4 days in the PICU and 1 day on the floor. After discharge, prolonged 3 to 4 week respiratory recovery period requiring albuterol, but since then has not had any recurrent wheezes. So before I go on, let me just answer your question to say that to me, in this case, this is a kid with reactive airway disease, not just wheezing from RSV. You need to document this in your notes. So if you think that it's a one-time wheezing, no way, that's an acute illness, you don't know. But if somebody had a prolonged course like that, yeah, you could say it's RSV, but very unlikely, and it's very reasonable for you as the clinician to say there is a reactive airway disease component here. I love this question. Okay, so she said, is there a difference if you code it wheezing or reactive airway disease? This is one of the points that Stephanie from the AAP wanted me to make sure people heard. You do not, oh, I do not have my glasses on. What does that say? 30 minutes, okay, thank you. When you, I lost my train of thought. Oh, yes, yeah. So if you have a definitive diagnosis like reactive airway disease, you do not also write wheezing. You are only putting the diagnosis codes of wheezing, etc., if you don't know that they have reactive airway disease. Does that make sense? So you have a definitive diagnosis. You could say, oh, I'm not sure if they're going to wheeze again. It might just be acute. You call that wheezing. If you think, no, this is recurrent, this is a wheezer, this is reactive airway disease, you just put reactive airway disease. With exacerbation, you can put. Yeah. We're getting to that too. The answer is, the question was, is wheezing a systemic symptom? Yes, but it doesn't mean you can use acute illness with systemic symptom. I'll get to that. All right. I know, sorry, love. So physical exam on this, the tympanic membranes are normal, nasal congestion, the lungs with diffuse wheezing and poor air entry, some mild retractions, the respiratory rate was 44 and the RSV was negative. Albuterol nebulizer was given with minimal improvement. A duo-neb treatment was then given, and at this point the patient improved dramatically with resolution of his tachypnea. So the diagnosis is reactive airway disease and viral syndrome, because I thought some of the symptoms were unrelated to the reactive airway disease. Clearly they have a cold also. The plan was to continue Q4 albuterol nebs, follow up in the office to recheck lungs, and the respiratory rate did improve to 27. How would we code this? I would code this a chronic illness with exacerbation, the reactive airway with the wheezing. This is a level 3 for data, as the parents were the historians, but only 1 test was done, not 2. And this is a level 4 for risk with prescription drug management. Even if you didn't send them home, you are managing them in the office with medication. Whether or not you send them home, this is a level 4 for risk. So we would code this a 99214 and a G2211. No questions, I love it. Yeah, sorry. I'm trying to keep, as some of these, sometimes people are saying, oh, what about time? Yeah, there's a lot of time as long as it's the time in the room. Yes, but sorry, I don't have all of the codes down. All right, vignette number 5. A 14-year-old female presents with mom who states that she has had a 2-day history of sore throat, nausea, abdominal discomfort, minimal congestion, headache, malaise, and fever. She was just at a friend's house who was diagnosed with strep throat. In addition, the patient had a UTI last month, and mom would like to test her urine. Her physical exam was significant for erythematous tonsils, palatal petechiae, and shoddy lymphadenopathy. The remainder of the physical exam is within normal limits. Labs done was the strep NAT was positive, and the urine analysis was negative. We diagnosed with strep throat, and we give amoxicillin for 10 days. So how is this coded? The problem is a level 3, an acute uncomplicated illness. This is not an acute illness with systemic symptoms. I'll get to that in my next slide. So this is probably one of the most frequently asked questions within BCD and also at the AAP. Remember that CPT is defining it. Yes, wheezing is a systemic symptom. So is the headache. So is the stomach ache. But it is not with a high risk of morbidity without treatment. People have argued with me when I've presented this case saying, but you could go on to have rheumatic fever. Yeah, but the chances of that are so small. So if you had a kid with strep, but they had a full body rash and you were concerned about toxic shock, okay, I'm with you. That is absolutely a systemic symptom, or you can do an undiagnosed new problem, but you have to have the high risk of morbidity without treatment. That is the key. I'm sorry. There's other ways to get to a 4. You're not going to get it that way. Please come. Yeah.
Situation like that, if they also reported dysphagia, systemic system?
Well, that, I would say no, because it hurts when you have a sore throat, like from strep. It's all related. They're all common symptoms. Yeah. Ooh. This, oh boy. Yeah. Right. I'm not good with that, but basically there's not a high risk just with fever, right? That's.
I think this slide is helpful because it defines what a systemic symptom is, and where it says high risk of morbidity without treatment, so would that symptom cause bodily harm if you didn't do anything about it?
Right.
And fever would not.
I mean, we may be fever phobic in New Jersey, but really it's going to be okay.
Everyone's fever phobic.
Yeah.
I'm not.
Jesse, go ahead.
Correct me, one of your later slides mentioned the urinalysis, and I have a problem because if you feel it's reasonable to do a UA on a female with abdominal pain, aren't you then defining that abdominal pain as a systemic symptom with...
I'm getting to that right here. Stay right there. Don't go anywhere. And I said, while I think it's appropriate to do a UA with abdominal pain, even though I think it's personally probably from the strep, the 14-year-old with nausea and abdominal discomfort, we have to be careful not to do a test just to get to a level 4 or because the parent wants the test. This test must be done if it's medically indicated. So if you think that the abdominal pain is unassociated with the strep, is really what it comes down to.
Which would lead me to think you are in fact dealing with systemic symptoms.
Then,
because the definition...
nobody's doubting that it's a systemic symptom. Everybody agrees that the headaches, the stomach aches from strep are systemic. There's just not a high risk of morbidity or mortality without treatment.
But by doing a UA, you're thinking UTI or pyelo, you're thinking possibly appendicitis.
In this, yeah.
But I think the fact of doing it...
I don't think that's actually true. You're not necessarily saying it. You may have it on your differential. In this case, the one point I wanted to make was, if a parent is concerned, but you're not concerned, it's not medically indicated. So you can do the test and report it to the insurance company, but you have to bill the parent for that test because in your mind, it's not medically indicated. Here, I think there was enough reason with a history to say, okay, maybe it's a UTI, I'm not that worried about it, but no, I don't think you can go on to say that that's a systemic symptom.
So your differential doesn't determine the systemic symptom according to the diagnosis. If your differential includes things that could be serious and could not be serious, that's not enough to get to an acute illness with systemic symptoms. Is that correct?
I disagree with that. I think what you're getting at, and I agree with what you're saying, is that one of the ways you get there is if you have things of high morbidity and mortality on your differential that you really think. But you don't put it there if you don't think it. So this is where the ethics come into play. Like, don't just say Pilo because, okay, well, that will get me an okay. No, do you really think it's Pilo, or do you really think that it's probably, as this case was, probably some stomach ache from the strep? But I'm going to do the UA just to make sure I'm not wrong, move on.
So
if you had back pain and there was something to really suspect it, then I think, yeah, and Pilo in and of itself is a systemic symptom. So that would get you to a level 4 visit right there, even though it's one system.
So it's all about the documentation.
It's all about documentation, yeah.
I really pity you trying to explain this. I have read everything online trying to explain this to my practice, and I would have hypertension and a stomach ache if I were you right now.
Yeah.
I feel like this is one of the poorest written things that has ever come out of the AMA. So this is, in all due respect, with the example of UTI versus Pilo, I have really even gone back, like maybe I'm just old. To me, Pilo is UTI with a fever, and they have chills, and they look ill. And when there's so few examples given by the AMA of what are, like, Pilo is not a systemic symptom. Pilo is a diagnosis. And so I've really gone back to, okay, what are the distinguishing factors that they're trying to identify Pilo versus UTA to use that as an example of those are systemic symptoms.
Right, so I'm gonna answer this and then move on, but I'm gonna say that Pilo is really a systemic symptom. You're having the fever, you're having the other associated symptoms with it, and a high risk of morbidity or mortality without treatment for sure. So I think you can absolutely get there with Pilo, and I think the AAP coding hotline would back me up on that. All right. Were you dying?
Well, the two of us, it's a 1-2.
Okay.
So first of all, talking about fever, when we were discussing it, difference between someone with 102 versus 105, higher the temperature. But with the UA being ordered with abdominal pain, that seems to be acceptable.
It's going to come down to the documentation in the specific situation.
So that's what I want to underscore. The people who read your notes, if you get audited, are coders. They are not diagnosticians. So eczema, you write, patient with chronic eczema expect to last greater than 1 year. Patient with acute, it's the documentation in your note that is you're either gonna make you or break you. Think out loud on paper. The coders are looking for check boxes. Look at what exactly the AMA wants and use the words back at them. If you think this patient with strep throat and vomiting as a systemic symptom, concerned that vomiting may make this patient not able to tolerate oral antibiotics and may have to come back for IM bicillin, that is a systemic symptom that's doing it, but don't make them up. This is not the hill you want to die on.
Yep.
Move on and go see your next patient with anxiety, which is going to take you 50 minutes and code by time.
All right, I'm going to move on. Hold your questions. I will get to more at the end. Vignette number 6. A 7-year-old female presents with 3 days of vomiting and 1 day of significant diarrhea, low energy, sleeping all day, and stomach pains. She is tolerating only minimal fluids, and mom says she has only urinated twice that day, and urine is very dark. Mom is a nurse practitioner and is not an alarmist, but she seems very concerned with her daughter. Her past medical history is significant for a UTI at 4 years old, but otherwise no concerns. Her physical exam is significant for an ill-appearing child. Her tonsils are minimally red, her abdomen is also minimally tender, no hepatosplenomegaly rebound or guarding. We ordered a flu, COVID, strep, and she was positive for strep. The UA has a spec grav of 1030 with ketones, but no nitrites or leukocytes. A urine culture was sent. I was very concerned. This was actually my patient. She has strep, but she really looked dehydrated with vomiting and diarrhea. So I prescribed amoxicillin. The patient is vomiting and struggling to keep fluids down. I discussed with mom sending her to the ER for fluids and blood work. I then called the ER to discuss the case with the attending. We decided that with a dose of Zofran and amoxicillin, that she may turn the corner. She was instructed to follow up with me in the morning. So this is an example of where strep can be a level 5 visit. The problem is level 4, an undiagnosed new problem of uncertain prognosis, because besides the strep, there seemed to me that there was more going on. I don't know about you, but I have literally never before prescribed Zofran for strep. The data was a level 5 because we had a category 1 of the independent historian and 2 tests were ordered, and a category 3 as the case was discussed with an external MD. And this was a risk of a level 5 with decision regarding hospitalization. Please keep in mind with the decision regarding hospitalization, if you're sending somebody to the ER for just fluids, that's not a level 5. But if you want fluids and evaluation for possible admission, then yes, that is a level 5 for risk. I just wanted to, we listened to all these vignettes. I just wanted to tell you what actually happened in this case. It was kind of crazy. The parents called the office at 7:30 to say that they were taking their daughter to the ER. I called the mom, and serendipitously, the ER attending had just finished examining the patient, and we had discussed a plan and labs to be done. In the lab, the ER, the BUN was 185, and the creatinine was 7.1. She basically had HUS and diagnosed with acute renal failure. The helicopter was busy, or she would have been helicoptered to Hackensack Hospital. She was transferred for emergency hemodialysis. She was actually found to have Shiga toxin-producing E. coli, EAEC, and sapovirus. After 2 weeks in the PICU, she was discharged home on Christmas Eve. 1 year later, she was doing well, and nephrology is cautiously optimistic for a full recovery. So I just wanted to finish it because it was such a crazy case, and to also just say, hey, trust your gut. I didn't like it that I was calling the ER attending, saying, I'm giving Zofran for strep, something just doesn't feel right, she looked so sick. I'm still mad at myself. The mom was a nurse practitioner. She was not mad at me, I was mad at myself. You know, the kid is fine. I don't know that 8 hours would have made that much of a difference, but still, it's just one of those things. I feel like I got lucky in this case. All right, vignette number 7. A 9-year-old male presents for his first visit in the office for an ADHD visit. He is transferring in as mom is unhappy with the front staff at the prior pediatrician. He was first diagnosed with ADHD 3 years ago by a neurologist, but was not started on medication at that time. Last year, he developed motor tics and was referred to CHOP for a full neuropsych evaluation. After the evaluation, he was started on clonidine, but that made him too sleepy, so we switched to guanfacine 1 milligram. This helped only modestly with his ADHD, and he developed some lower BPs, so a stimulant was recommended. He was put on Vyvanse 10 milligrams and increased to 20 milligrams. He was having some increased concentration issues in the last 2 months. In addition, mom has noted some increased tics in the last 2 weeks. The past medical history is significant for ADHD, asthma, eczema, amblyopia, TNA, blah, blah, blah. His current meds are guanfacine and Vyvanse 20 milligrams. The physical is normal, no concerns. He's diagnosed with ADHD and a tic disorder. The plan was to increase the Vyvanse to 30 milligrams and continue the guanfacine, and if increase in motor tics was seen, to decrease back to 20 milligrams. I wanted to make sure to get this all in to give you a time-based example. So this is a 12 minutes were spent prior to the visit reviewing all the records. There was 41 minutes spent face-to-face with this patient, 7 minutes documenting, 4 minutes spent writing for medication, and a total time of 64 minutes. So coding by time, this is a new patient, you get a 99205, that's 60 minutes, and a G2211. The key is, what if this was not a new patient? Yes, you still have a 99215, but do not forget about the prolonged care code of the 99417. You get 40 minutes, that's all you need in these new definition. It's not a range, it's not 40 to 50, so you only have to hit 55 minutes to get 1 unit of the 99417. So don't forget this. This is huge. This changed drastically in our office, and we're starting to use this more. The visit would have had to have been more than 70 minutes to bill an additional unit, but you can have additional units of the 99417. I can't hear you. You never know, it could be a new problem. If you spent that time, you gotta look at it with this. This is the time of the visit. I'm just saying, let's say he had been seen for a flu shot, and now they're not a new patient anymore, but now you're reviewing everything. So that's the point. Number 8, I know I got like 10 minutes. She's gonna flash something up, I don't have a lot of time. Okay, I got that. A 21-month-old male, new to the practice, sorry for all these new patients, there's a problem with them, presents with 1 day after a hospital discharge for presumed febrile seizure and choking episode. Again, this was my patient, I'm very lucky. He is here today because he needs medical clearance for myringotomy tube placement tomorrow. Patient was well until 2 days ago on day of admission when he developed a fever and had a seizure lasting 30 seconds. Shortly after the seizure, mom drove him to the hospital, but on the way he had a choking spell and then another seizure. The mom pulled him over to the side of the road and called 911. He had 2 additional shaking episodes followed by full body limpness, each episode lasting about 15 seconds. When EMS arrived, he was no longer seizing, but he was clearly in a state of altered mental status. The patient was evaluated in the ER and found to have 106 fever and was given Rocephin, and a partial sepsis workup was done. He was admitted to the floor for observation because of his high fever with no source and multiple seizures. His 1-day hospitalization was uneventful. He seemed to return to his normal baseline later that evening. All blood work was normal, CBC, CRP, CMP, and blood and urine cultures were pending. He did have an additional fever at 2 a.m., but no subsequent seizures. Later that afternoon, he was discharged home. I'll have you know, and the ENT called me to say, "Why are you not clearing him?" No joke. The day after discharge, he was seen in the office. He was back to baseline, eating, playing, and acting normally. Normal physical exam, but he was not cleared for MT2 placement. He was not sent home on any medications. Cultures were negative to date, and therefore he decided not to give additional Rocephin. The past medical history is significant for eczema and developmental delays and concerns of autism, just to throw in another one. The differential was febrile seizures, infection, seizure disorder. There were multiple things on the differential. This patient was new to me and really was just supposed to be a quick sick visit to clear him for tubes. The diagnosis are seizure and fever. So how did I code this? The problem is a level 4 for an undiagnosed new problem of uncertain prognosis. Is this febrile seizures? Is this a seizure disorder? We're not really sure. This is a level 4 for data. The mom is the historian and multiple labs were reviewed that were done. And the prescription drug management was discussed, even though the Rocephin was not given. So this would have been a 99204 and a G2211. But instead, I built this as a transition of care code, a 99495. So, transition of care management. I have like 3 minutes to talk about it. That's a joke. But I just want to bring this up, and you can read the slides to say there are a lot of requirements. Do not let the requirements overwhelm you. This is the most highly paid code we have in pediatric offices. The thing you need to remember is, besides all the rules, is you can't do anything else with that visit. So don't give shots. You can't bill for the shots. Don't do anything. Pulse ox is whatever it is, it's not billed with it. If the other things are so important you do, don't bill it a transition of care because you're not going to get billed. You're not going to get paid on the other things. So you can read in the charts what are the requirements of the transition of care. 99% of the transition of care in our pediatric office are of moderate level. It's either a 99495 or 96 for high. What do you need to do? You need to have contact with the family or the doctor within 2 days of discharge, business days, that is. You can't just say, hey, how are you? You have to do certain things at this 2-day visit. You have to find out what happened in the hospital. You have to have medication reconciliation, date of admission, date of discharge, etc. We have a protocol that Jan is willing to share with all of you that very nicely outlines everything that you need to have, as you can see right here, basically in that encounter when you first see them. Besides seeing them within, having contact within 2 days, you need to see them within 14 days for it to be billed a moderately complex visit. This is a transition from any higher level institution. So it doesn't have to just be a hospital or an ICU. It can be from drug rehab, an eating disorder residential program, anything when they're going from transitioning back from a higher level of care to outpatient. The common mistakes that we see in this office, this is probably the biggest one that I see at BCD, is that at the time of the visit, when you're seeing them in the office, you must have a level 4 for medical decision-making at that time, or a level 5. If it's a level 5, then you could possibly qualify if you follow the other requirements for a highly complex transition of care code. And I just want to encourage you all to do it. Look into the code. Yes, it's annoying, but it's worth it. It's really, I mean, I don't know if I'm allowed to say what our average payment is, but it's probably 2 to 2.5 times the 99215, I would say. All right, almost there. Let me see, if I have to pick, I'm going to pick this one. This might be my last one. Where am I? Yeah. Okay, a 2-year-old male presents for a well visit with his mom. History and physical are performed and all appropriate counseling is done. The patient was noted to have a left ear infection on exam. The patient has not had a recent illness, just some minimal ongoing congestion. A separate sick note is documented and amoxicillin is prescribed. He was diagnosed as a well child visit and a left otitis. We bill this for the preventive established patient as well as the diagnosis code of the encounter for routine child health with exam with abnormal findings and the acute serous. And then there is the leveling for the MDM section, which is a level 3 visit. So you would get a 99213-25. This is a modified visit now, so you cannot bill a G2211. Yes, actually, but it doesn't matter, correct, but it doesn't matter which it is once you have a modified visit. Yeah, thank you for that. This is really important. When is it that you can bill a separate sick visit when you're doing a well visit? The way coding guidelines state it is you have to do a significant amount of work to create an extra E&M visit. So in this case, yes, you would be looking in the ears, but you have to prescribe amoxicillin, and it's medication management, and it's a whole separate thing. But if you noted a diaper rash on the well visit and you give them zinc oxide, then no, that's not considered a significant amount of work. So yes, there are nuances. You can see more cases, but I think this is a clear example of 2 things that we see all the time. Ear infection, yes. Diaper rash, no. In general, just know that about 5% on average of well visits should be coded with accompanying sick. If you're doing a lot more than these, there's probably something really wrong, and you're probably way overcoding this. And I am concerned for you because the insurance companies post-COVID are all into take-backs. So this is one of the things that they're going to be looking at. So if you feel like you're overcoding this, please reevaluate your process. Okay, I have 2 minutes, so let me just skip, unfortunately, to the very end and just say, in terms of documenting, we have to document to be good doctors, right? That's the most important thing. Yes, we have to prove our coding, and then we need to protect ourselves in case of lawsuits. So BCD has a really nice add-on component to all of our visits that you can just hit the drop-down menu for which level, and you can quickly type in what it is for risk, for problem, for data, and for risk. So when we do our self-coding audits, we then can say, oh, this is what the provider was thinking, and yes, it's justified, or no, it's not. And it's a learning process for the clinicians as well as for the coders, and that's where these sort of discussions arose. It's also really nice for the billing department when they reject something, they can just cut and paste that MDM section and say, well, this is our justification for the code. And that's basically it. So, oh, that's fascinating. There's a session takeaway. I don't know if I even wrote that. But basically, the bottom line is document. And I think that's it. Sorry. I'll take questions. I know we're over on time, but if anybody wants to ask anything quickly. I got 40 seconds.
Okay. I had two. One was big discussion among our group and between groups, every time you prescribe a medicine, whether it's triamcinolone or Benadryl in a prescription, you know, this, you take this much and you write it down. That's a 214?
No, not for an over-the-counter medication.
Okay, so any antibiotic,
Any prescription medication.
Okay, no matter what, it's a 214.
Pretty much no matter what, yep.
Okay.
For risk.
Right.
For risk, yeah. It's not two, it doesn't qualify.
Yeah.
Okay. And then the second one is with the extended time code, the 99417, is it incorrect that you have to reach the 60 minutes first? You have to get 60 and then you have to get to 15 before you can bill
Correct.
it? Okay, because I thought it didn't add up. But maybe-
It didn't add up in the new patient visit, right? So you would have needed 75 minutes.
Right.
And we only had 64 minutes. That's why you couldn't use it in the new patient. But with the established patient, it would add up.
Okay, all right, thank you.
Okay, so real quick, we had a strep test denied. And so basically the patient presented, it was in the winter, with fever and a sore throat were the first two complaints, and then all these other symptoms. So several tests were done. It wasn't the E&M code that was rejected, it was the strep test. The final diagnosis was influenza, and that was how it was sent. So it was sent back rejected, so we wrote something, and they said it was basically, I don't remember how many times we went back and forth, but really the question is that just like a crazy one-off that I should just, I mean, obviously we're going to appeal it, but is that something that's happening? I mean, it seems ridiculous that you have to write sore throat symptom as a diagnosis.
That's what you do, though.
You do.
That's what you do.
You have to link something to the test to justify the test.
To justify the test.
It
So
doesn't
that's
ha-
something that like the billers and the coders should be
I
aware
think
of.
fever should usually qualify for it if you're having a fever and you're linking the fever with it. But
Yeah.
I mean, because a lot of kids with strep don't have sore throat. So, but as long as it was probably what it was linked to would be my guess.
Probably what it was
I don't know,
linked to.
Tiana. I don't think we have this problem that much, but yeah. Dan?
That kind of goes against the using the most salient diagnosis. If you already have something, influenza, then the symptoms you usually wouldn't put, but I guess in the case you do. This is really just a comment going back to the one that was real sick, went to the hospital at night. And it's all judgment calls and stuff like that. But I mean, it sounds like even if you hadn't spoken to the ER doctor, you could have gotten on the problem. It could have been a 5 as, acute illness with threat to life or bodily harm or something.
I can barely hear you. You're
Yeah,
saying that we would have gotten to a level 5 for risk, you mean?
For risk, because it was acute problem with threat to life or bodily harm. I mean, if you thought she was that sick that she was maybe dehydrated, needed IV fluids and stuff, if you don't get it, I mean.
Yes,
so-
correct. I
yeah.
think, unfortunately, I wasn't, if I had really felt that way, I would have sent them, and I guess I was torturing myself, but that's the reason. But yes, you are correct. Go ahead, before I get kicked off.
You did a great job with that patient. Don't torture yourself.
Oh, thank you.
I want to